database. Now, for purposes of this training, I am going to go through EID briefly because it's also, I think, part of HIV care. So now, I am going to assume that probably maybe this mother came, this was 20th of August. So I am going to use maybe this same date to just demonstrate EID. So if this mother, remember the mother was pregnant, if this mother came and gave birth to an exposed infant, so what happens is we shall go through this later, but now if this mother produced a child and this child, yes, it's a live birth, but then this child is exposed. So if I come here and I put this, of course, it's bringing me this field, and then I'll be able to come and add my baby here, and then I'll put that, assuming this child is yes, yeah, it's maybe born today. I am just trying to use today's date. So if I register this child here, if I say save child here, now my child, this child is recorded here, and of course we shall see it in the next session of MCH. So if this child comes here, now assuming this is an exposed child, I should be able to provide EID services when I am still in the profile of the mother. So when you register the child, these children keep on adding here. And as we shall see later in the expanded MCH session. So now, for part of this training, I am going to show you how to provide EID under the profile of the mother. So now, when you register the child, the child's profile comes here. And then you'll be able to finish the profile of the mother. But through this, if I click on this, I will have this part that comes. Now, if I want to provide EID services, so this child health services section has been embedded under this maternity profile. So if this child is being enrolled in EID, into ID, I will still under the profile of the mother, I should be able to come and register the child here. So this is the ATS number. If the child initiates nevirapine today, this is nevirapine. Okay, yeah, today you put that date. Then given first time at mother baby care, I will indicate this, the risk status high or low. And then I will actually fill all these fields that are applicable on this visit. And because if this is at birth, maybe I'll indicate those. I have put this. So you'll fill all the other things that are as they were in the EID register or EI chart, and then you should be able to save this child. And I call this child Flora baby, something like that. So if I come and I save here, I am going to save my visit. So if I save my visit, now this child here has been registered in the system. So if I come back later, I am assuming now the child was registered at delivery or was enrolled into EID care, and now I want to come and add a second PCR. So this child is already in the system as a client. So what I will do, I'll just come here and search, because now the child becomes a client or a record in the system. And I think this is the baby. So if this baby comes, now if this baby is here, I will be able to open this. And as you can see, there is this visit here. So I am going to add the second PCR now. So first PCR. And if I open the record, so I'll just come here and select child health services. and now it will come. So if it comes, this time I will just come here and select EID, and I will go on and put the other details. I'll put the number if I have the mother's AT number, and now here I will be able to provide my all the appropriate services. If this person is given all these, one we already filled these ones here, but then if this person is given Confirmax as of today, I will indicate that, and then I will put these other ones, this other information about the mother, and then now I will come here and select my PCR tests. They are here. So if this time I am giving first PCR, I will be able to come and I select the date the PCR is done, and then testing point, all these ones here, date dispatched. I indicate if the sample is taken today, PCR date, results received. Like I said, now here, some of these ones might not be filled today. So you will actually have to wait until the results come. So when the results come, we'll come and update. So you will actually update all these other fields as appropriate. So if someone is initiated on CTX today, you'll put that. And of course, you'll indicate if the mother is on ARVs on this visit, you will have this infant feeding status. You'll pick this, and then to assess this, I don't think this is applicable. So now, and the outcome, of course, depending on the visit, you'll actually select appropriately. This is filled at the end. So now, I have left my results here, because you might not get, if maybe the sample was taken sent CPHL, of course, you'll not get the results then and then. So what happens is I can save my visit now. So when I save my visit, and then later, at a later date, I am able to get the results for this PCR test. So I will just come here, search this child. When I am here, I will just come here and edit this information, and then I will be able to come and update this field here of results when they come. So if they come, I am sorry, apologies, I'm using one date, but if they come, I'll just come and indicate when they come, are they positive or negative? And then I should be able to still save my updated record. So this is how EID information is captured through the mother's profile, right from the time of registration. Alternatively, if maybe this was a home delivery, you will still come here and register this child. Enroll the child into EID, you register, put the names and the right, and then you go and select Child Health Services and be able to register this child. If probably maybe it was a home delivery, and if the baby is not delivered in the health facility. So you have this option of registering this child without going through the mother's profile. So if I say register client here, I should be able to come and now click add visit, and I'll come and select Child Health Services, and then I should be able to enroll this child into EID if the child was not enrolled at the point of delivery, or maybe if it was a home delivery. So this is how the HIV data is captured across board, and so and of course the general HIV and then the EID care. So the other part of EMTCT will be covered under MCH, because now those other services, the HIV care is in that is integrated in MCH. So as we go through MCH section, we'll be able to look at the testing and enrollment into care under those services. So I have 10 minutes. I'm going to go through TB very fast.
John,
Yes.
I want to thank you very much for the wonderful presentation. but it would be just fair that at least between now and before you go for the TB, you pick at least 3 questions from the people that have been paying attention from the start of your presentation. That's all, colleagues. If you want to ask, feel free to put up your hand, and you'll be allowed an opportunity to unmute and speak to us. And as they do that, we already have the 3 hands, so I think that's enough for this session. We'll keep taking more questions. Feel free to type in the chat, and you'll be given an opportunity to unmute and speak to us. So we'll take Sadat, Moses, Edgar, and Joshua Kamlega in that order. Yeah, so after those 3, the rest of you can type in the chat, and we'll probably also provide another opportunity much later. So Sadat, over to you. Sadat, if you're speaking, we can't hear you. Unmute. Sadat, unmute. Okay, Sadat, I think is struggling to unmute. Joshua, you can go, and then you can go first, and then we'll get Sadat again.
So good afternoon, team, and thank you for the presentation. My question is about index testing and the SNS. I think it's good to take us through how index and the SNS is linked to HTS, because we know it's one of the key indicators that we are reporting on in DHIS2. Thank you.
Okay, thank you, Joshua. Moses, are you in position to ask now? If you can unmute, you have an opportunity to. Okay, as Moses prepares to unmute, Sadat, you can have Edgar.
Okay,
Dr. Edgar.
thank you. Thank you, Benedict. Mine more or less of suggestions for system improvement. I noted that when we started the presentation, we started by entering a new client and went directly to RT. If I didn't miss anything, then I want to suggest that we could start with search. This client could actually be in the system, having attended this same facility for some other service. So if we start with search, then maybe we would be able to add this client. And then now the question comes: so when we do search, how far ago do we stop? Is it a person who attended last year? Is it a person who attended 3 years ago, or this month? So that one is not coming out well. I have also noted as a number 2 that there's a struggle of assigning numbers. I wanted to propose that if eventually we get system auto-generated numbers, it should work across all service areas, so that you don't have a number for OPD, a number for laboratory, a number for MCH, and etc. So that we have that one. On HTS special category, I think you need to put a provision for not applicable, because you have already automated them, and not everybody will be special category. So we don't have to leave it blank. On HIV test result, we have positive, negative, and intermediate. Then on registration, the reason I am thinking we start with triage, because now the issue of diabetes, hypertension, those are done at triage, and I see they are still again appearing in the what? In the HTS clinic. So we can have these ones done at triage, then the system auto-populates itself, so that when you come to the RT card, you don't have to again do these things. For all the tests that we are doing, I am proposing, e.g. viral load, put done or not done, so that when it's not done, then the windows of viral load results, what it was, the same with CD4, same with the test you displayed, so that the window of results, see what happened, they don't come up. Lastly, Lastly is on follow-up status. I think you started well when you put in the drop-down box. Active, roast follow-up, died. Then you again continue and said died to do this, died to do this. I am suggesting that you keep it the original, active, lost follow-up, died down. Now, if died, if you want to capture cause of death, I'm proposing that the auto-populate ICD-11 so that the diagnosis across board is standard. Thank you.
Okay, that is well noted. Because Edgar asked a number of questions, I would want to invite our panelists to give a few responses to those sets of questions, and then we proceed from there. The rest of us, feel free to use the Q&A, and then the panelists, I will request that you use the Q&A to be making some responses there. Casivante, John, Michael, let's be making some responses in the chat, and then we'll be able to answer those that will come out from the mouthpiece. John, over to you.
Okay, and yes, you called on the other panelists. So to begin with, yes, so I had continued, but ideally you were supposed to first search, and then if the client is there, you should continue and add the services like you can see here. So if this client was the same client I was looking at, if the client was there, then you and maybe you had come for OPD previously, you'll search, and then you should be able to proceed and add a service to this client. So basically, and that's what we went through yesterday. So today I was continuing, but that is the procedure. And thank you, Dr. Edgar, for reminding everyone on that. So yes, it's a practice. You first search, and then you go ahead and add the services. Then in terms of someone who asked about SNS and the indexes. So what happens is we have contact tracing in this system, but it's sorry, I forgot about this. So we have provided for contact tracing for 3 services: HIV, TB, and leprosy. So every time you come here and select any of those services, if you select ART, you will see contact tracing coming. So if you select TB, here, you see it's not there, but then if you select TB, you see it coming. So now if this was ART, now the contact tracing will actually come here, and then you should be able to trace these contacts that are linked to that client. So now, of course, like I said, we have the options here: HIV, TB, and leprosy. And now if you say HIV, you should be able to register these different contacts, and then the contact type we have index client and social networks here. So the contacts are also provided for in this system, and thank you for reminding me on this. So if you register all these clients, you should be able to have this data aggregated and reported. Philip, can you add on this?
So thank you so much, John. Thank you so much, Tim. So basically, that's what it's going to be. So, and it's good that you actually asked this question. So when you click on just like John mentioned, for someone to have a test, let's say an index client, you must have started with a client who's HIV positive. So then that will give you all the index, all their contacts. So, you know, those that can be able to test. So here you just have to select, like you said, and then we'll be able to get this information. And then this information will be aggregated for us to be able to do even a line listing if we want to know whether we are able to test all their contacts, the index and the social, and those that we are picking from the social network strategy. Thank you.
Okay, thank you, Philip. And then the other one was about the having done or not done for the other test viral load on a clinical visit day. Yeah, so I think Philip, I don't know, maybe we need to discuss that further, But
Yes.
for now, post we are only providing for if you do it, you indicate. Probably if you don't do it, empty, of course, an empty field might not mean you probably didn't do it, but it is something I think that we need to discuss further outside this after this meeting.
Yes.
Then the issues of test of the special category. Yeah, like I said, you see, we are trying to make this register user-friendly and simplified. So we didn't want to put so many restrictions, but like I still said, if someone is not a special category, you will actually leave the field. And if someone is a special category, you'll be able to fill it. So we were trying to balance not putting a lot of restrictions, while at the same time catering for all the available or needed fields or data for reporting or for decision making. So we were torn between those decisions. That's why you see some of the fields will be there for every visit, even when they are not applicable, for you to be able to pick appropriately. And I think that is the training we need to provide to all the users of the system. In terms of the results negative, I don't know, but I think people went through these results. We had so many discussions about the different possible results. So, but it is, I think, Dr. Edgar, we can always also discuss with you on the results and probably come and inform the rest of the every other person. But I know we went through all those back and forth of which results to consider. And I think that's how we ended up with those. So then the other one is, I think the ICD. If someone dies, we need to integrate the other form. So those are other things that will actually happen later. Yeah, they are in the pipeline, but for now, we are trying to capture the data, and then these other things will come on board, or we start integrating in these other things as guided by the ministry. But yes, Dr. Edgar, some of these things are on progress, and they will be probably integrated at the right time. Then the follow-up status, I think Philip also on this, we were trying to provide all the different outcomes for any type of client and for any type of follow-up. So we were trying to look at what was applicable in most of the tools. So we put whole of that list. So actually, whatever client you are looking at, you should be able to indicate the possible outcome of that visit. So that was also an amalgam, like a combination of the different outcomes for the different types of clients under HIV management. I think,
and indeed, John, you're right on that. So,
yes.
like colleagues, so what you see is what we have in the current tools. So, if you find some of the suggestions that Edgar gave are very good, we are going to see how it can pre-populate some of the sections and all that. But there's also this is a system, and the more it does those pre-populating of some of those sections, it might also slow down. So, but we are also exploring all that to see that we can have that information put there. About the testing results, we picked that straight from the HTS register. So that's what we have in the HTS register: positive, negative, inconclusive. So those are the results that we have. Then the outcomes, like John said, we are looking at the registers that we have, and we are populating and mimicking what is there to see that we can pick as all the information that we have to pick in there. But that said, we still can review this and see if there's anything that we have missed out. We can be able to really see how to incorporate it. Thank you. Back to you.
And
Okay,
lastly,
yes, go-
there is the issue of searching. You can only search within your health facility. And for now, since we don't have numbers, we feel you can be able to search among all the clients ever registered against your facility. So we'll actually explore, maybe as numbers grow, we'll be able to find out if you can search, if the searching is going to be affected. But for now, you will search among the clients that have ever been registered against that health facility or under that health facility. So for now, it's limited to one facility. where your user account is tagged to. So, and Chair Ben, like I said, I am moving on, but I request that we do TB tomorrow. I want to request that Joanne continues with MCH, and we'll be able to cover TB tomorrow.
Okay, thank you, John. Since we are closing the HIV discussion, let's take these last 3 hands that are here and we close it off completely. And also, just to request that you graduate Moses to the panelist side so that he also manages to respond to some of the questions. Remove Moses. Yes, so Geoffrey and Sadat, if you're able to unmute, kindly ask those 2 questions. Geoffrey and Sadat, strictly those that had their hands up. Geoffrey, you can go first. Globa, unmute and speak to us. If you're speaking, we can't hear you. Okay, Sadat, please unmute and speak to us. So they are unable to speak. Some hands are very hard to reject. We have to give an opportunity to Senior Dr. Wilford Chilunji to chip in now. Kindly let Dr. Wilford speak to us.
Okay, thank you, Bernard, and everyone. Yeah, I'm relieved to see the progress we have made, but I want to be very brief. So, 2 things that yesterday I joined you for a short time. I could have missed many things, and today I joined you later. If at the end of the day, I wanted to summarize the list of people I've attended to, I don't know, there must be a report function which can list the clients I've seen that day. Is that possible? And then secondly, before I come to the clinic, I want to review an appointment list. So from all the clients that we have, maybe this particular day, I expect certain 20 individuals. So I'm able to also generate that list from the report. I'm sure there must be some report module. And maybe the third bit of the question is, now that this is online, would it be possible to incorporate alert functions? The following people were meant to have come, they didn't show up, or send reminders to, through SMS? Is the system, it looks very impressive system. They want to imagine that maybe it has those kind of functionalities as well.
Okay. Thank you, Dr. Chilunji. Yeah, so John, you can make those responses and then we proceed. John, are you able to hear me? Kindly make responses to Dr. Chilunji's questions and then we proceed. Maybe John has dropped off the call, but Dr. Chilunji, just to respond to a few of your questions is, yes, the reporting module is there, and you can be able to extract lists, line lists of the clients that you have worked on for a day, and given a particular type of service. So that is very possible. And then also, you're able to generate at the end of the reporting period, say weekly, monthly, and quarterly, you're able to generate reports from the services that you have been offering and the data, using the data you have been capturing. So you don't need to again go and tally and do the manual tally it is auto-generated, and you just have to click buttons and push data into the reporting system, the national EHM ones. I don't know if I missed part of your questions, Dr. Chilonji, but largely I think it was around the reporting.
Yeah, and maybe generating reminders, automated reminders, or other alerts, you know, foreign clients have not showed up if they were expected, you know. Like
Yes, so right now, this system is just like the register we had in the facility. It does not operate like an EMR to be able to do a lot of functionality. It's limited in functionality, but at least you're able to generate a list of the people that are due for a certain service. You can be able to see that someone was scheduled to take up like a load or do something, and then they defaulted. That list is able to be, you can be able to generate that for follow-up and the other steps. Yeah, so that is very possible, but not the notifications, because it also has an offline functionality. So in an offline setting, the automated reminders may not work. Yes, so that is it, Dr. Chilunji. I hope I've...
yeah, thank you. Yeah, that's good enough.
Yeah, thank you very much, colleagues. So, but as we leave this HIV section, for us to know, this system is a work in progress, and we are continuing to make it more functional by fixing those gaps that are still there. Yeah, most importantly, I wanted us to consider John and our in-house team getting in something like visit type, where we have new and follow-up visit. That will help us to apply skip logics for people that are visiting for the first time, so that we don't see information like viral load testing for people that are starting, and the follow-up sections for the first timers. Yes, so thank you very much. We can now hand it over to Joan to take us through the next session. Joan, over to you.
Thank you so much, Ben, and good afternoon, everyone. I am going to take us through the aspects of maternal health in the next 1 hour. And again, I invite the rest of the panelists to come in and answer questions as we go. Yeah, so I think one of us has requested, instead of registering a client, that we start with a client who is already existing. And I've also seen questions on how do you search. So I'll take this opportunity to just let us know that we have such parameters here that you can enter. And also I have seen a lot of questions around searching and not finding a client. And one of the biggest causes of that is a mix-up of the first name and the last name. Sometimes we register Joan Nachibuka, with Joan being the first name and Nachibuka the surname. But when you come to search, you're entering Nachibuka as a first name. So you will not see that client. So make sure that when you're searching, you're not mixing up these names. So I'm going to search for a client who is already existing. We have quite a number of test clients. So search by test. And once I enter on my computer or click the search button, I'm able to get a list of the clients that I have on the system. And because I want to demonstrate aspects of maternal health, I'm going to get a female client. And in this case, I'll go ahead and try to get one of my female clients here. You can see that I've put the surname and it has filtered out for me the test client that I want, who is Meritus Mukisa. Once I have this client appearing here, I can click on their name, and this is directly going to open for me the client dashboard that you still see if you register this client. Now, once I'm here, as I think John demonstrated yesterday and today, I'm able to minimize the profile using that arrow there, so that I have a better screen size to work with. Then I can go ahead and add a visit. Definitely, we need the visit date because we are using this to be able to get the age at visit based on your date of birth and the date when you came to visit the facility. And we all know that this is for purposes of populating our reports, which are disaggregated by age when you visited for the services that you got at the facility. So I am going to assume that maybe this client visited today and they came for antenatal. We'll first go through the antenatal. Yesterday, we went through the triage details. And again, I am hoping that if you were not able to attend yesterday, we were able to access the recording for that session of yesterday. But basically here, you're taking down the vitals of the client, whether they were referral in, their weights. I'll assume maybe this mother is 80 kilograms, their height, 155 centimeters, their temperature. And I'm not going to spend a lot of time here because we want to focus more on the ins and outs of antenatal and maternity for the remaining time that we have on this webinar. We are dealing with a pregnant mother. Here I'm going to skip some things. Of course, we know that for pregnant mothers, we use MWAC, and we have the mark here. If it's 24, this is a mother who is not malnourished. And then you can also go ahead and enter the rest as they are available to you. Yesterday, there was also screening. You need to screen this mother for quite a number of things, TB, leprosy, sickle cell, and some NCDs are available here. And important to note that for hypertension and as well as diabetes, because the variables that we need for screening of these particular conditions are available in triage, we are not repeating them under screening. So make sure that the pressure measurements, the measurements of blood glucose, you have recorded them so that you can we can be able to classify the client. So I'll go straight to antenatal. And again, here we are starting with the ANC number. I think we still have the same kind of requests to automate these numbers, but we said that as we try to balance the automation serially, because serial is important for these numbers, as well as availing the offline functionality. In the facilities, we encourage that members try to track these numbers off of the system as they enter them in the system so that a person knows where someone stopped and where someone else is able to pick up. Then we go ahead to the visit number. Here we have up to 8 visits, assuming this is the first visit for this mother. We have the gravida and the parity, where I think the gravida is the total number of pregnancies, and then the parity, those that have gone beyond, I think, 28 weeks. I could be corrected by another person on the program, but make sure that you enter those numbers correctly. If there are 5, here you can say 3. If you put gravida to be greater than parity, we shall also not allow you to proceed because that is information that is not correct. Then the gestation age in weeks. If, for example, we say that this mother has come at 10 weeks for the first visit, you notice that here in the ANC1 timing, we are auto-populating the ANC1 timing because according to the register, you either get your first visit below 12 weeks, below or equal to 12 weeks or above 12 weeks. The program is really monitoring that, but we've automated that based on the visit number and the gestation age. And then also you can be able to select the expected date of delivery, which is in the future. As you can see, you can't select a date in the past. I'll just put a date there. But we expect that as the midwives are attending to these mothers, make sure that you've entered the gestation age and then also estimate the date of delivery based on the different modalities as you've been doing it in the registers and recording. And then we have the HIV status. So it's from here that we are picking whether you are newly tested HIV positive. We combine the HIV status and we expect that at this point, you're running an HIV test for this mother. So if this mother is positive, and we are seeing that the timing of the HIV test in ANC is fast, then under the report, we shall be able to populate those as a newly tested HIV positive for the first time this pregnancy. Then we go ahead to the to find out if they've come with their partner for the first time in ANC. And if they've come with their partner, then what is the partner's status? If they are positive or if they are negative, then there is a partner's facility HIV test, assuming this is also negative. Then we shall be able to also go ahead and record the self-testing kit for the partner if we give them the self-testing kit. If yes, I think you can see that we are getting additional parameters as partner STK result, the self-testing kit result. It is here, assuming that still the partner was negative. But we said here that the woman is positive, so we are able to see the ART status of this mother. Whether they are new on ART, whether it's a non-ART, or they are getting a refill for this particular visit. So assuming they are new on ART, the ART linkage number, you'll be able to input it. And then the CD4 count, assuming, let us say 500. Infant ARV prophylaxis. I think this is a misplaced and find out if this mother is eligible, an HIV positive mother. If yes, we'll fill there. What was the date when the viral load was collected? It is that. What was the result? We can also input and say maybe 1,000. Then the scan, if it was done, the weeks that it indicated, we can say maybe 12. The blood glucose rhesus, we have these options, assuming this is a positive mother. Then also the HB level, assuming it's 15. Then we are also monitoring malaria testing in mothers. If it was done, give us a result. Was it positive? Was it negative? And again, if you didn't do the test, you can also record that the test was not done. But assuming this was a negative result, you can always select any that is applicable. We are also keen on the sickle cell screening, or the program is keen on sickle cell screening. And as it was in the register, you should be able to tell us if you have screened, is this mother AA, AS, or SS? Assuming they are AA, you should also be able to tell us. Input the, I think another parameter from the lab for the mothers is protein in urine, glucose in urine. If they were tested for syphilis, there are these different codes. Now, these codes have been defined in the registers. And we are hoping that the clinicians or whoever is attending to these clients is aware of what is RX1, because it's a really long definition. We can't put it on the system here, but we also encourage, based on what we have seen, people are asking, what does RX1 mean? What does RX2 mean? We encourage that at facility level, please make reference to what is on the paper register, or pull it out and even just pin it for everyone to be able to get to know what these different codes mean. But each of these has a meaning that was part of the definitions in the register. If the partner was tested for syphilis, we also have the same drop down here for the results of syphilis. Then we have Hep B test result for the partner, if it was done. So we have the positive, we have the negative, or if the test was not done, you should also be able to indicate that. Then we have the hepatitis B test result for the woman. If it wasn't done, then you should be able to indicate that. If it was done, tell us whether it was a positive or a negative. And this is, again, as they were in the register. Then woman's eligibility for ARVs, since we are dealing with an HIV positive woman, we can say that the client was eligible and initiated on ARVs. Then under ANC, we also have some conditions that are picked up and are tracked. And these have been made available in this drop down, whether the mother had any other condition during this ANC that was picked up. If it was not a normal pregnancy, you can say it was a normal pregnancy. But if they had maybe bacterial vaginosis, you can select as many, candidiasis, you can select as many as possible here or as applicable. We have made this multi-select. Then IPT, you're also filling. If they were given a net, you should also tell us whether they were given a net. We need that information because it's part of what we use to populate in the report. Then the deworming mebendazole. If you gave the mother, you should be able to tell us that you gave the mother mebendazole. Then a pregnant woman's vaccination status. This is where we have all the vaccines that are given to pregnant mothers, starting with a TD 1 up to 5, and then the Hep B, dose 1 to dose 5. Assuming at this visit, this mother got the first dose of TD. Then we have the micronutrient supplementation. You are supposed to record how many tablets you've given the mother for these micronutrients, starting from folic acid, assuming that you gave this mother 30 tablets, you record, iron and folic, you record. If you have not given the mother, please do not be forced to record. You only record what you have given. Then we also have the MMS, where I think we are giving a tin, which has 180 tablets for now. So you should be able to give us that. Then if you're giving the mother any other treatment, you should be able to record any other treatment that you've given the mother. And again, I'm being hypothetical here because I want us to go over the fields that are available in the ANC register. If the mother has any complication, you should also be able to state there are quite a number of complications that we have been given from the maternal health department to include here. So you should be able to also tell us if they have any complication. And again, this is a multi-select data element. Now you need to set the next appointment date. And it is from this field of next appointment date that when we go to our line listing, we are able to line list and filter out the mothers that are due for a test in a certain period, which was one of the questions that came up in the earlier discussion. And you can see that this is a date in the future. So if we are giving them the next appointment date, probably they'll come back next month on the 20th. And this is it for the ANC. You have filled what you have to fill as per the records that have been collected. Then you go ahead and save this visit. So you will see that we have the sync status as pending. I've also seen a question on what does pending mean in this particular aspect. So pending means we have saved this record. We have it stored on your device, which could be the computer, which could be the tablet or the phone. And what does this mean? That automatically, once you pull data, which we went through yesterday, and you have records on your device, you're technically working with the records you have on your device until you want to send this to the server. So pending means you have not yet sent this to the server. Please go ahead and push data. Once you push the data, this pushing data requires that you're connected and you have internet. It should be able to sync or show that you have synced the data here. So what happens when this mother is due for delivery? I am going to go through maternity, then we can take the questions at once. So if this mother is due for delivery, we can still go ahead and search for this mother. This is our mother. We can see that we have their records already as they have been coming to the facility. And again, this is hypothetical because we are trying to demo the two services on the same day. So we are going to still add a maternity visit, assuming they came on another day when they have to deliver. We add the visit date. Please make sure you're entering the right date. Again, this is hypothetical for purposes of demonstration. Select that this mother has come for maternity. Now, under maternity, we have quite a number of things that we track or that need you to admit the mother. And I think we are all aware of this. One of them is that they are in active labor. but they can also be admitted for malaria in pregnancy and any other conditions, as we'll see. Again, I am not going to go over the triage, because this is something that you need to do whenever a client comes to the facility. Take down their vitals, as we said. Then under screening, you still screen the mother. They've come for maternity, but you need to screen them for some conditions. So we shall go straight to maternity, which is our point of focus. Now, under maternity, we have tried to section these service points or this service type based on the different times when data is entered about a mother who has come to give birth. And we are saying give birth because a mother can be admitted for many reasons, as we said, but labor and delivery has a lot much more you capture about the mother than the other conditions that lead to admission of a mother in maternity. And one of the fields to start with is the date and time of admission. Let us assume that this mother came yesterday. They came yesterday maybe at around 1 a.m., 8 minutes past 1. So you're able to select the different date and time as applicable. Then you give them an admission number. And again, we have talked about the numbers, and we are still trying to devise a means of trying to generate them. Then the gravida and parity, you still enter that. Then the gestation week, assuming that this mother is delivering at week 39. So that means that this is a term baby. So the reason for admission, these are the different reasons that we have as per the maternity register. Assuming our mother is in active labor, we shall select that they are in active labor. But we also have these other reasons as they were in the maternity register. Now, under the delivery information section of the register, we had still the woman's HIV status. Again, assuming they were positive, and this is a retest. Test for verification showed that they were positive. Then we have all these other information, the whole clinical staging, the viral load. And again, allow me to just demonstrate this. I may not be able to enter the actual expected results. Assuming the mother CD4 count is 200, since they are positive, you need to know their HIV status, they are known at. Then also we do some partner test recording in maternity. So if this was positive, you can see that if the partner is positive, we also need to know the ART status of the partner. If they are known at, then whether they are initiated on CTX or not, assuming that is what is applicable. If the partner was tested for syphilis, basically what we have here is similar to what we have in antenatal, and this is how we had it in the physical register. The hepatitis B test for the woman, if it is positive, what is her eligibility for ARVs? That is also available. If they are negative, then we shall not see that eligibility. If not done, we shall not see that eligibility. Same applies to the partner's hepatitis B test result. Now we also go ahead to record the mode of delivery for this mother. And we have these three. If they had SVD, then you should be able to select that. And you tell us that they delivered today at maybe 3 minutes past 2. You should be able to give us the date and time of delivery. Now here we have a very important field, which is live births. We need to know if it was a live birth or not for different purposes. The first purpose is if it was a live birth. We are working on the integration of this with the NIRA to be able to notify live births that have been recorded in the e-register. If it was not a live birth, we also need to record that so that we are able to do the perinatal death notification from the e-register. So whichever selection you make here is going to trigger a registration of a child. When you say that the child was born alive, the registration date is by default the date that we are recording. Then you have to give us the surname. And sometimes the argument is these babies don't have names, but we need to use the same modality that we have been using to record in the physical registers to be able to record here in the e-register, because we need to notify that a baby was born. So we shall go ahead and register using some pseudonyming here. Maybe the baby doesn't have a name. We can say baby of Joanna. And maybe if the father was Joseph, we can go ahead and say the first name we are giving them is baby of Joseph. And these are really not permanent, because we saw that on our profile, we can edit. Whenever this baby comes back and they have an actual name, we can go ahead and edit their profile. Because what we are doing here with this registration is that we are registering this child as a client on the e-register. Because even within maternity, we are going to give them some services, as we'll see. Then you register the sex of the child, assuming it's a male child. You'll notice that the date of birth has been picked from the date of delivery. And then we have to also tell whether they are a national refugee or foreigner for purposes of our reporting. We have other variables here, the NIN, the client ID, but they are not mandatory. When you come here to the address, you will notice that we have picked the mother's address as the address of this particular child. Then we have also gone ahead and auto-populated under parents' details. We are auto-populating the mother's name, the mother's phone number as they are in the profile of the mother. They are not repeating entry here because we are using them to notify this child's birth. We have also gone ahead to pick the father's address as the mother's address, but we left it editable in case this the father is staying in a different place from the mother. You can see that you can edit, but we also have the father's nationality, the mother's nationality that you should fill, and you're able to go ahead and save the child. Now we have also got questions of what happens if this is a multiple birth. We have twins, we have triplets, we have quadruplets. Here is where you go. You save child and add another. So when I say save child and add another, it is going to save my first child, and then I'm going to go ahead and add another child. Maybe baby of Joanna 2, baby of Joseph 2. This is a male. We shall still go ahead and say they are national. And then as we saw, we have the rest of the details captured here. Then we can save the child. Now, once you have saved the child, you can go ahead and continue entering the mother's details. Oxytocin, active management of third stage of labor, what was used, and again, we have already made this multi-select. If you haven't received a multi-selection on this particular data element, please do a full metadata sync as we demonstrated yesterday, so that you're able to get these particular changes. Management procedure for complications, PPH management. We've also made this multi-select because there was a request that you can use more than one. Then you can do the post-delivery information. If the mother breastfed within the 1 hour, did you check the mother for excessive bleeding at 6 hours? Yes. What was the pressure at 6 hours of the mother? You should be able to do to record that. Then care 24 hours, whether you check the mother for excessive bleeding, and then the pressure of the mother report. Did you give IYCF counseling? Yes. If no, you should also be able to tell us. But if you say that you gave it, what are the options that you gave? You should be able to select either exclusive breastfeeding, replacement feeding, or mixed feeding. This should be available for you to select. Then what is a mother's final diagnosis? These are the options that we had. So this was a normal delivery. Was maternal counseling, nutrition counseling done? You tell us whether it's a yes or no. Did the mother have danger signs? We have, they had danger signs or not. You should be able to also tell us that. Then the condition of the mother at discharge. You should tell us maybe the mother was discharged alive, or when the mother was discharged, maybe I'll still put today, but we all know that if it's normal delivery, it was 24 hours. So you're probably filling these particular details the next day, but because we are demonstrating, I'll just go ahead and select a date there. And if you give them other treatments, you should be able to select which other treatments you gave them. Then also there are referrals where the mother is required to be referred out even before you fill all these different details. We have also put that particular data element there, and then you tell us where you referred this mother, even if you did, given that you didn't give them the full care for one reason or the other. Now you'll see I use the mother who was already in the system and they already had babies. But for now, let us just focus on this baby, our baby of Joseph 2 and baby of Joseph, baby of Joanna. You see that these are the two babies that we have who have been registered on the system. Now, there are details of the babies that you capture during maternity. And this is where you go ahead and capture those details. We shall demonstrate with one baby. Let us assume we are working now on this baby. And again, the timing at which you do it is really based on the workflow that is happening or that people are following at the facility. There is a child number. You also fill the child number. And again, still this is part of the numbers discussion that we have had. Then we have the details. If it was a term baby, what was the outcome? For as long as they were alive and we were all alive and sick, we shall see more details. But if they were dead, then we can just take the baby's weight, assuming this baby was maybe 3.8 kilograms, and they were maybe 46 centimeters. Then we go straight to the condition at discharge. If the baby was dead, then you'll be able to see macerated stillbirth, fresh stillbirth, or immediate neonatal death within 24 hours. Now, what happens if the baby is alive? Whether they're alive and sick or alive and well, we are able to see some more parameters. And these include the APGAR score at 1 minute. I may not enter the right numbers. You also do the APGAR score at 5 minutes. Whether the baby was resuscitated at birth, if the baby was normal, they didn't need that. Was there immediate skin to skin? Yes. Then we have the kangaroo mother care. I think that is the KMC. You should also be able to go and tell us whether that was done. If it was not applicable, you should also say not applicable. The essential care given, code KRT or vitamin K, you can select all those. What was the infant's risk status? If it was high, then you can see that we go ahead to ask whether ARVs were administered to the baby. If it was low or not applicable, that should be able to hide. Then we look at the care at 6 hours, whether we gave the code care, was the code checked, breastfeeding at 6 hours, the breathing, did we check the breathing at 6 hours? At 24 hours, we are still doing that recording of the baby care at these different times. Breastfeeding at 24 hours, breathing at 24 hours, did we check the baby's breathing at that particular timing? And then we also record the baby's condition at discharge. And because it was a live baby, you can also see what we have for a live baby who is well. And if it was a live baby who is sick, we shall also go ahead and see that we have some other different parameters for those babies that are born with defects. Then we should go ahead and also record whether we gave this child a NET. Now, there is something else that is very important. Within the NCD department, there is a sickle cell screening in maternity. If you have what it takes to do the sickle cell screening in maternity, please go ahead and record that you did the screening and also indicate the result for that particular screening based on what you find. This has also been added as one of the things that we are recording within the e-register. Now, we know that this child gets immunization at birth. So even before you leave here, you can go ahead and add an immunization service. And you can see that down here, we have the immunization where we have the service location. It's at the facility. If this baby's mother was given the TD as the definition of protection at birth, you should be able to say that this child was protected at birth. Then we have the vaccination timing, where you're selecting whether you're giving vaccines that are for birth, 6 weeks, 10 weeks, as well as the vitamins and dewormers. And I think this one we shall also get a day when we go through the immunization and the other child health services that we provide. But this child is getting the birth doses, which is 0, polio 0, BCG, Hep B birth dose. They got those doses today. You can give them a next appointment date, but you can also go ahead and fill some other parameters that are required here for a child who is vaccinated. Assuming they are supposed to come back 6 weeks from now, I'll not count right now, but I will just fill in something there in the future. And again, this is for purposes of seeing which children are due for which vaccination, as we'll see when we come to the part of line listing and being able to tease out what we need to get as per the next appointment dates that we have filled. So we are able to also give immunization within maternity. If the child was exposed, as John demonstrated, you can also go ahead and add that this child was exposed, and we shall get the EID section that John demonstrated before, which I'm not going to repeat. So basically, I want to emphasize this workflow. Reason being, we've had some facilities that they would register the mother, and then they go ahead and add child's health services to the mother, and then they add some details that are not attached to that child. So please make sure that if this child was born, whether alive or dead, fill in the pop-up that comes for registering the child, and you'll find this child's details after the mother's details. Then you'll go ahead and enter that particular information. Then we can save our visit. Once we save our visit and we go back and we search for baby of, I think it was baby of Joseph. I hope I'm not mixing up the first name and the surname. You'll see that we have a baby of Joanna, baby of Joseph, and already we see that they got child health services. And once we go to their child health services, we can find what they got. I hope this is a child that we registered. Yeah, so that is the whole essence of this particular flow. And why we have integrated them is because we didn't want people to go back and forth, register the mother, register the child, but do the registration within the same interface. Yes, I think I want to end that here, tending to the end. Thank you so much, and back to you, Chair. Back to you, Chair.
Thank you very much, Joan, for the wonderful presentation. Yeah, it's been lengthy, but I hope we have managed to follow through. We have 3 hands up, and we'll take Richard Barton, Simon Epi, and Musana Henry in that order, and we get responses. Yes, Richard, you can go first, and then Simon and Musana in that order. Richard, please unmute. We are unable to hear.
He's calling for Richard. Richard Barton. Hello.
the other gadgets next to you. Richard, so as Richard prepares, we can get Simon. Simon, you can go, and then we'll get Richard later on as well. Yes, Simon? Simon, we can't hear you. Simon, your channel is unmute, but we can't hear you. So let's try Henry. Henry, try speaking to us. Musana Henry. The host can help us to unmute those people. I think they are struggling to unmute. Richard, we can have Richard, Simon, Kennedy Omona, in position to speak. Someone unmute Omona. Yes, Omona, you can unmute and speak to us. Yeah, so I think we are getting challenges with the people unmuting. Richard and Omona, you have the opportunity.
Thank you, Chair.
Yes,
I think it was by mistake. That's why I raised my hand. So let's continue.
Okay, Omona. Richard mute. Omona. So I think we can take on some questions from the chat as we wait for the people to be able to unmute and speak to us. I can see there are questions here. Please, team, I have 11 data which is still failing to pull. What could be the problem? That's John, you'll be able to respond. That's from Charles. And then Alan, when am I supposed to use the register new client and add another? What scenario do I use? The icon. And then we have Brenda. What happens in case we are working offline and lab results are fed in the lab personnel by the lab personnel and the clinician when the patient comes back from the lab won't see these results. Yeah, so John, I think you can respond to those three, and then we'll try again picking people that will speak to us. John, over to you.
All right. Thank you so much, Ben, and thanks colleagues for the questions. And again, I also want to thank you for the suggestions. As a matter of fact, we have been picking up some of the suggestions and feedback that we are getting, and we are recording that. And if we indicate that this has been picked up, please note that it has indeed been picked up. Now, for the questions that we have, the three, I'll start with the question of when do I use register and add another? So that depends on the workflow you have at the facility. There are some facilities where we have people that are registering somewhere and they keep registering and then the clients move on. They register, the clients move on and they get triaged and things like that. So that's when you have to register and add another. Register and add another provides you with an opportunity of saving the current client, and then you fill in a profile for another client. That is register and add another. Then the next question was on being able to pull data. There is one thing that we have also noticed: if the page is a bit open for some time, you need to refresh. The refresh is this, you need to refresh the page or just close the page and open it. Your data is not going to be lost. And then you'll be able to click the pull button. Sometimes you click on it and it's not responding. But one thing for sure that you should do, the first thing that you do in terms of troubleshooting that particular challenge is refreshing the page. And some people have gone as far as logging out and logging back in, which does the same thing because you basically are refreshing the page, and then you'll be able to have this pull sync metadata and push data active. And sometimes if you're not pulling all that data, that's also may be a problem. So I'll just go over this quickly. Pull data will give you data from the last time you pulled. Basically, it's just pulling the changes that you don't have from the last time you pulled. But if you want to be sure that you've received all the data, then go to this drop down arrow and say pull all data. So pull all data is going to help you pull all the data for your facility ever since they started using the e-register, or ever since they started pushing data for e-register to the server. And the same applies to syncing metadata. You should do a full metadata sync using this arrow whenever you're not seeing some of the changes that we have indicated or communicated that we have made. So that particular refreshing and also trying to pull all data should be able to help or support you to overcome that particular challenge. How do we go about triage when we have gone for community testing, or we just add a patient? Please register the client, triage them, and enter the information that you have provided to the client as is, as we have seen in the register. I think those were the 3 questions. Ben.
Yes, thank you, John. You have responded very well to all of them. So we can try again to see if we'll be lucky to get someone speaking to us. Omona, Nkolo, Regan, and Kevin Kenge. In that order. Omona? Omona, unmute and ask your question. Kennedy, Omona. Regan, Nkolo.
Yes, thank you so much, sir. Good evening, colleagues. My name is Amuko Regan, Data Clerk Namugongo, that is the Kario district. Now, my question is, we've been receiving data calls whereby you just go and count from the register straight. But now this time around, you're having e-register. Could you please take us through on how we can download data on certain indicators which you may need to present or to discuss as a facility team? That's my question.
Okay, that is clear. So they will take you through the line listing and reporting components for you to be able to respond to your data calls. Kevin?
Okay, thank you so much. Thank you so much for the presentations. My concern is about the partners when we are sending these couples to the laboratory. It is becoming kind of hectic to enter them separately. I don't know that there can be a provision for us like to send the tests at a go at that point, or that part of testing both clients, okay, this couple. Then the other thing is about postnatal, because like there are 2 parts. There is where you put services, maybe like, for example, child health services. I may put postnatal as a service up, but again, when you come down within the child health services, there is also another part for postnatal. So I'm really wondering which one exactly should we use? The one of the services up or the one within the child health services? Thank you.
Okay, the very last one, Omona. This is the last time we are giving Omona a chance. Ivan Mukono. Let's allow Ivan to speak, and then we'll respond to those and call it a day. Ivan? Yes, Ivan, you should be able to speak now.
Yes, thank you very much, Chair. Can you hear me?
Yes, we can hear you, Ivan.
Okay, thank you. This is Mwesigo Ivan, Data Clerk, Sheshel Center 3 in Uganda. I wanted us to emphasize on HIV testing in all entry points because when we are generating these reports at the end of the month or end of the week, we find that people are being tested in other entry points, but because they are not including the HTS service type on those visits, we find out that the HTS is underutilized. So as we are presenting, I wanted us to emphasize that so that at each and every point, so long as the client has been tested for HIV, they should be able to add the HTS service type for those clients. And then another thing is that some errors I've seen within our facilities that I have been able to support is that when it comes to antenatal, now these medicines that they give, let's say ferrous and then folic acid, our dear midwives have been stopping at entering those medicines or commodities under the antenatal register, and hence fail to add them under these medicines and supplies, which also affects the report at the end of the month or end of the week. Those are my concerns. Thank you very much.
Thank you. So I think John, you can respond to those questions and we call it a day.
All right, thank you so much, Ivan. I think Ivan's concerns are more of us, for all of us who are on the call. Again, if I repeat what he's suggesting, I'll be just regurgitating what he's suggesting for all of us. But basically, what you should be seeing is that whenever you have a service type, for example, if I add a service type here, the HIV testing that we are doing is at different points. So whether you're in outpatient and you did HTS, you should be able to add the HTS service type. So you have both the outpatient and the HTS, so that you're able to provide the HTS service that a person who came for OPD has received. So irrespective of the service point where you're at, you can add another service point, and that's a good case for HTS as it's done at the different points in the facility. So I think that is also very important. And I think we shall keep stressing it, Ivan. Thank you so much for bringing it up. Then I think for the other question that was on postnatal, now you see we have, what I demonstrated is that you're in maternity, and so you're in maternity and you're able to register the child and you're able to go ahead and provide them other services. So you'll notice that even neonatal IPD is also attached in case the child went for IPD. And also we give some services to the child at postnatal. Now, why we also included that is that in case this mother comes and they've come for postnatal, and you're giving the mother services at postnatal, without exiting this interface, you're also able to give the child the services that you give them when they come with the mother at postnatal. So you go ahead and add the postnatal section for this mother. So what does this mean? This means that for this particular child, you're entering data about the services, the check you've done on the child at postnatal within the mother's postnatal interface, but this information is being stored about the child. So what happens if this child does not come back with the mother for postnatal? Maybe sadly the mother passed away, but they have come for their 6 weeks check. Then you can go ahead and just search for the child and select Child Health Services, and then you go to the postnatal section and you're able to record this information about the child. So that is a distinction between what we are making available within maternity and postnatal versus what you receive when you select Child Health Services as the service type. So either works, but we want to ease the workflow for our healthcare workers. If you're seeing the mother and they are there with their child, then you don't have to search for the child to register or record the postnatal information. You can just go ahead and click on the child below the mother's information and you add postnatal and you give them. But if this child comes without the mother and you have to see them as the child, then you're also able to access the postnatal section as a child health service that you're giving to this child at 6 weeks, at 6 months, or at 1 week, I think. The 3 times when they come back for check post-delivery. So that is a distinction between the two. Then I also want to stress, Ben, before we go, you see that on this screen I have 2 notifications, and that is something that we are going to be sending out. Whenever we make a change to the system, we shall be sending out a notification to everybody that we have made a change to the system. Please refresh or sync metadata. And you see the one that is in yellow is about an update that we shall be doing to the application itself. And normally we shall tell you that refresh to pick changes that we made to the application. But before you refresh, sometimes you forget, sometimes you're not aware that we have made the change. So we shall be pushing out this notification, and please do not ignore them. Once you get them, make sure that you respond by clicking the buttons that we are seeing, either reloading or syncing metadata. We are going to be triggering you to actually reload and sync metadata as and when we make the changes. When you see these notifications on your screens, kindly go ahead and push the buttons that we have provided so that we do not miss out on the changes that we have made to the system. Ben, over to you, and thank you so much.
Yes, thank you very much, colleagues, for being patient up to this time. The Q&A session does not end here. We'll be able to extract it with answers that have been given, and then we'll share with you via the platforms that are available for us to reach out to you. But also, most important to note is that this hand-holding is not a one-off. It's not just for these webinar series that we are having. We have put in place some channels for you to be supported. You have regional supervisors and support teams, and we expect that you have WhatsApp groups that you have created. And the other expectation is that you're able to meet at least once a week to keep track of what is happening, share insights on the updates, the changes, and all the information that you feel the team should be updated about. So on a weekly basis, you should have an engagement, you should have a meeting. Then also those support channels, those WhatsApp groups that you have, in case you're facing a challenge, you're supposed to communicate it through the channels that you have in place. So as we conclude today's meeting, this is general information for us. With the digital systems that we are rolling out, we expect you to get challenges. But once you get the challenges, this is how you should get help in a timely manner. So we have instituted the tiers of support, the HIS support mechanisms that we are asking all of you to embrace, starting with the facility level, which is tier 0. So at the facility level, you do not want to cause an impression that the whole team is at the same level of understanding. Like you heard from Ivan Mwesigo here, he's already suggesting solutions of what has actually worked in his setting. So if you're facing a challenge, feel free to reach out to a colleague at the facility and ask on the how-to so that you get assistance within the facility. So in case they are not able to address the issue, you drop it in the facility WhatsApp group for someone to see. If they are not able to answer, then you can escalate to tier 1. Tier 1 is the district level. So at the district, we have IPs, we have the biostat, the HIS, and the data class. And then we also have a WhatsApp group at that level, and we expect you to be supported through that WhatsApp group at the district level. If that help is not sufficient, you're supposed to escalate to tier 2, that's the regional level, where we have the knowledgeable technicians, the regional IPs, the district biostats from the different local governments. We also have regional referral biostats now, and the different managers at that level. So at that level, we expect you to have monthly meetings. A group that I've talked about should convene monthly meetings to look at the issues that are emerging from time to time, the HIS-related issues. And in that meeting, you should write a report that you later submit to the ministry, or be able to also escalate issues from that meeting. So at that level, you also have a WhatsApp group. So if the region is not able to address certain issues, they're escalated to the ministry. We have a community, a WhatsApp community that merges the different regional WhatsApp groups. And then we have the ministry call center, which can be accessed through that number that you're seeing here on the screen. Yes, we also have the help desk. So tomorrow, last day for the webinar session, I will invite someone here to take us through the help desk as one of the channels that are available that you can use to get support from the issues that we'll be getting from time to time. You can also write through that email, and your concern will be taken care of. Yeah, so these are channels that we have put in place in order to be able to support you and ensure business continuity at all times. So at the national level, if we are not able to resolve, we also escalate to the development team, that is tier 4. So why all this? We want you to be able to get timely help instead of putting a lot of issues to the national team that will become so burdensome. We ask that you use the levels of support within your means and that are next to you for quick help and ensuring business continuity. So it also helps to make sure that there is we lower the turnaround time for response to issues. And we, of course, lessen the burden on the national team, like I already mentioned. So this is very important, colleagues, and let's continue to preach this gospel and make use of the available channels. Once again, I want to thank you very much and wish you a blessed evening. The meeting is adjourned. See you tomorrow, same time. Remind the colleagues that missed, they can access this information through the YouTube channels. Bye.
Thank you, Ben. Bye. Thanks, everybody.
Thank you.